Congenital heart diseases. There are several, and sometimes they're difficult to remember, but I'm going to go over each and every one of them now and hopefully make it easier for you to know. Tetralogy of Fallot, of course. Transposition of the great vessels. Tricuspid atresia. Persistent truncus arteriosus. Total anomalous pulmonary venous return. Patent ductus arteriosus, and coarctation of the aorta. Within all of these, you're going to have one or two other anomalies, either a VSD, an ASD, or both, a ventricular septal defect, an atrial septal defect, or both for the shunting of the blood. Now, the ventricular septal defect, the hole between the two ventricles, it's going to be the most common cardiac anomaly out there. It's associated with fetal alcohol syndrome and the trisomies 13, 18, and 21. And on physical exam, it's one of the only defects you're going to hear a holosystolic murmur for. Now, the atrial septal defect, an ASD, left untreated, it's often investigated when there are unknown reasons for multiple embolic strokes to the brain in an adult patient. And also classically, on physical exam, it's associated with a split S2 on heart sounds. So let's go over all of these one at a time. Let's start with Tetralogy of Fallot. Tetra, it means four. So classically, there are going to be four things that you find in Tetralogy of Fallot. You're going to have a ventricular septal defect, pulmonary stenosis, right ventricular hypertrophy, and an aorta that overrides that ventricular septal defect. Now, the reason you're going to have the right ventricular hypertrophy is because it's going to be pushing against both a stenotic pulmonary entrance, and also there's going to be some amount of left to right shunting, causing enlargement of that right ventricle. Tetralogy of Fallot is the most common cause of infantile cyanosis, or what's known as TET spells. TET spells are when the peripheral vasculature is not receiving enough oxygen and becomes cyanotic and turns a bluish color. Now, classically, these TET spells are relieved by squatting, an older individual squatting. The blood is cyanotic. There's not enough oxygen in the blood. And by squatting, you're increasing the peripheral resistance and forcing a left to right shunt of the blood. What does that do? It forces more blood into the pulmonary circulation to grab oxygen. So, in a Tetralogy of Fallot patient, they're going to be cyanotic because there's going to be a degree of right unoxygenated blood to left shunting being sent into the circulation. And when that is too much and the patient becomes cyanotic in the periphery, they may increase the peripheral resistance by squatting, shunt the blood back from left to right, trying to force some of that unoxygenated blood back into the lungs. On X-ray, you're going to see a boot-shaped heart, and I think of the right ventricular hypertrophy causing some of that. The treatment for Tetralogy of Fallot is surgical correction. Next, transposition of the great vessels. What great vessels? It's the pulmonary artery and the aorta. So when you transposition those, when you flip those, what you create is this circulation that's separated. The aorta is now over the right ventricle, and the pulmonic artery is now associated with the left ventricle. And remember, those should be switched. This transposition of the great vessels is associated with maternal diabetes, and a chest X-ray shows a classic eggs on a string appearance. A newborn will unfortunately not survive this anomaly unless there's some kind of shunting going on. Next, tricuspid atresia. Tricuspid atresia is simply an absent tricuspid valve. You're going to have a hypoplastic or small right ventricle, underdeveloped, and this anomaly is going to need both an ASD and a VSD for survival. Persistent truncus arteriosus, this is a failure of the separation of the pulmonary trunk from the aorta with development. Total anomalous pulmonary venous return. This is when the pulmonary veins, which should be draining into the left side of the heart, instead drain right back into the right side of the heart. So this blood that's received oxygen already is going back into the lungs, oxygenated already. It's sending it back into pulmonary circulation. Patent ductus arteriosus. This is normal in the developing fetus because you need a shunting of blood from the right side of the heart to the left. We're not going into the lungs yet. We haven't been born. But once we're born and the pressure in the lungs drops and allows for the blood to be oxygenated by breathing, that patent ductus arteriosus should close. But if it stays open, on physical exam, you're going to hear a classic continuous machine-like murmur, and the treatment is indomethacin. Indomethacin will decrease PGE. PGE is the factor that's maintaining the ductus open. And finally, coarctation of the aorta is classically associated with Turner syndrome, a bicuspid aortic valve, rib notching seen on X-ray due to collateral circulation, and high blood pressure in the upper extremities.